Dr. Denny, you're muted.
Marielle, do you want to get started or wait a few more minutes for other folks to join?
Let's get started because we have just 1 hour to do.
Okay, sounds good. And as other people trickle in, they can just join us then. So good afternoon, everyone, and welcome to Let's Talk About Cholesterol, working together to improve brain and heart health. I am Carter Denny, and I'm a stroke neurologist based in Washington, D.C. at MedStar Health and Georgetown University School of Medicine. And I am grateful to be part of the Connect Consortium, which includes a multidisciplinary team of people interested in stroke prevention and recovery, and led by Dr. Sharif at UTHealth in Houston, but we have representation from researchers and clinicians from across the country. So we're really excited to bring you this webinar, and thank you so much for joining us for today. So we know that cholesterol management can sometimes feel confusing or overwhelming, especially with so much information available. And our goal today is to provide practical, easy to understand information and create an open conversation about prevention, treatment, lifestyle changes, and lived experience from people who have had challenges with cholesterol and looking to sort of future directions for treatment. So I'll pass it over to Marielle, who is my co-moderator today.
Hello, everybody. My name is Marielle Flick Rojas. I'm a research coordinator at UTHealth Houston. So today I'll be co-moderated with Dr. Denny, this amazing panel. So today we're fortunate actually to have a multidisciplinary panel that includes preventive neurologists, cardiologists, pharmacists, nurse, and stroke survivor. Each one of them bringing valuable expertise and personal insights to this conversation. So today's format will include a short presentation, followed by a panel discussion and time for the audience to do your questions. So we encourage you to submit questions through the webinar using the Q&A feature. So before we begin, we review a few CME and housekeeping instructions. So in order to obtain your CME, you need to go to CME University, and you can actually scan the QR code here on the screen. So instructions to get it done will be there like in a PDF format. But basically, you need to go to cmeuniversity.com, create a new account. Then after logging in, you'll be asked to verify your information. You're going to type in the number of the event, that is 19569. And then it's going to appear a claim CME credits post-test evaluation. You click in the activity when it appears, and then you choose the type of credit that you desire. Depending on whatever you decide to claim, it depends if you're a physician, nursing, or pharmacy, it's going to have a post-test passing score of 70, and you need to score above 75 or better. And then after that, you complete your evaluation and you receive your continuing education certificate to download. Of course, after this webinar, we're going to be sharing on the email some further instructions in case you didn't have a chance to scan this QR code. So, Dr. Denny?
Thanks. So first off, we have Dr. Sara Doyle, who is a neurologist at UTHealth San Antonio, and her work focuses on stroke prevention, vascular neurology, and improving brain health through preventative care. Dr. Doyle, do you want to introduce yourself or add anything else?
No, good morning or afternoon, new afternoon, everyone, depending on where you are. It's really nice to be with you all and to discuss this across from both the physician and care coordinators and patient perspectives, because this is an evolving field, especially for neurology, being ever 30 years behind cardiology.
All right. Well, thank you, Dr. Doyle. And we're also joined by Dr. Ijeoma Isiadinso, who's an associate professor of medicine and medical director of the preventative cardiology program at Emory Healthcare in Atlanta. Her expertise includes cholesterol management, cardiovascular risk reduction, and heart disease prevention. Thanks for being here, Dr. Isiadinso. Anything you'd like to add today?
No, I just want to express my gratitude for the invitation to be part of this discussion. I think the collaboration between cardiologists and neurologists is especially important. We've got patients who are dealing with vascular issues across the spectrum of our specialties, and we can't do it alone. So I like this collaborative work.
Thank you so much. Joining us as well is Brooklym Olumba, who's a clinical pharmacist and brings expertise in medication management, patient education, and helping individuals navigate cholesterol-lowering therapies and preventive care. Brooklyn, thank you for being here.
So excited to be here. I run the charity clinic, the Medication Therapy and Wellness Clinic at Memorial Hermann Southwest. So we have, a very unique patient population that needs a lot of support, especially post-stroke. We see a lot of those patients who come in for management of their blood pressure, diabetes, lipids, all kinds of things. So I'm really excited to be a part of the panel and contribute my perspective as a pharmacist.
Thank you so much. We also welcome Maria Jamilla Lacap, who's a nurse practitioner from UT Physicians in Houston, who works closely with patients and families to support stroke recovery, education, and long-term health management. Thank you for being here, Maria.
Hi, good afternoon, all. Thank you for the invitation. Really excited to speak. Work closely with the neurology department with Dr. Sharif and our stroke patients. So happy to provide the insight and this collaborative effort.
Thank you so much. And finally, we are most honored to have Cheryl Benton joining us as a stroke survivor and advocate. Cheryl brings an important lived experience perspective today, and will share insights about her recovery, stroke prevention, and the personal impact of stroke on individuals and families. So welcome, Cheryl.
Thank you, Dr. Dene. I am literally honored to be here with this whole team of high-level professionals, and I thank you as my neurologist for including me in this, because it's not often the survivors get an opportunity to participate. So I'm very pleased, and thank you very much.
Thank you, Cheryl. So thank you all for being here today and sharing your expertise and experiences with our audience. And with that, I'll turn it back to Marielle.
So yeah, today we're going to start, as I said in the beginning, with a presentation with Dr. Ijeoma Isiadinso, who will give an introduction with the updates on the cholesterol guidelines and their alignment with secondary stroke prevention. So Dr. Isiadinso, whenever you're ready, the panel is yours.
Thank you. Are you able to see my slides right now?
Yes.
Wonderful. So, I want to provide a little bit of background and specifically talk about how we can help work together towards secondary prevention of stroke. And so I'm going to go ahead and dive right in. I have no disclosures that are relevant to this particular talk. So to provide a little bit of background, firstly, when I use the terms cardiovascular disease, because I know that we have a mixed audience today, so I want to provide this foundation about what I was going to be talking about and some of the terms I'm going to be using. So when we're talking about cardiovascular disease, we're talking about both cardiac disease as well as diseases of the vascular system. And that's where stroke comes into play. So stroke and peripheral arterial disease, whether it's the carotid arteries or the leg arteries, that falls under peripheral arteries. And so peripheral arterial disease is a disease process that affects those vessels. So cardiovascular disease, the combination of those two vascular systems. In 2023, coronary heart disease was the leading cause of death in the United States, followed closely by stroke. And so this is why it's so important to be talking about how do we prevent not just secondary strokes, but even the first strokes, is because it is the #2 cause of death in the United States. Every year, 800,000 individuals experience a stroke, whether new or recurrent, but of the 800,000, 185,000 of those are actually people who have had a previous stroke. There are 3 different types of strokes that we'll be discussing today. The first being ischemic strokes, and that's the most common component or type of stroke when we're talking about strokes. It makes up about 90% of strokes that occur, and it's because of a blockage that occurs that impairs blood flow to the brain. 10% of strokes are because of a bleed or a ruptured vessel that causes a bleed in the brain, an intracerebral hemorrhage. And the least common is a subarachnoid hemorrhage, when there's a bleed in the space around the brain. Well, one thing we know is that although strokes are common, they are unique to specific age groups, in that although strokes can occur in younger individuals, it's very rare. As you can see, it's less than even 0.5%. But as you start to increase in age, you see that there's a greater occurrence of strokes. And that's primarily because the risk factors for stroke also increase as one gets older. As you can also see here, that as women get older, that's when we start to see that their risk of stroke starts to increase, but they tend to lag behind men, especially sort of in that middle age group. So this slide summarizes the risk factors for stroke. What I like about this is I'm dividing it here into modifiable risk factors and non-modifiable risk factors. And that's especially important because you can't treat what you don't know. Modifiable risk factors are the ones that you can actually change. Non-modifiable risk factors are the ones that you cannot change, such as your age, your gender, your race. What's important to note is those top 4, hypertension, AFib, dyslipidemia, and diabetes, are the leading preventable causes of stroke. And so that's important because there are things that we can do to reduce our risk of having a second stroke or even the first stroke if you have any of these risk factors. Additionally, you see smoking is a risk factor for stroke. Obesity, but not just obesity, but physical inactivity. A diet that's high in sodium or excessive saturated fats, alcohol use, sleep disorders, and certain other cardiovascular diseases are also causes for stroke. Let me just get another sip here. Another non-modifiable risk factor is if you've had a prior stroke or TIA. And that's one of the strongest predictors of an individual having another stroke. It's also important to know that there are higher stroke rates among Black individuals compared to whites, and in some Hispanic populations as well. As you saw from the graph that I presented initially, men tend to have a higher incidence of strokes at a younger age, but women start to track closely behind them as they get older. The important thing to note also is that now that you know what some of the modifiable risk factors are, is that almost 90% of the stroke risk can be modified or reduced if you actually can address those modifiable risk factors. So it is imperative that we are aggressively addressing those risk factors once they've been identified in an individual. 50% of the stroke risk actually is due to behavioral risk factors, such as the obesity, sedentary lifestyle, unhealthy diet, and smoking. And so there's great opportunity here to address those risk factors to prevent an individual from having a second or third stroke. When it comes to hypertension, both the systolic and diastolic blood pressure are important when it comes to the risk of stroke. And I'll be talking about some of the lipid guidelines from our 2026 ACC-AHA dyslipidemia guideline. But one of the recommendations that's going to be important is to make sure we target LDL cholesterol. So now that we have goals to treat towards for those who have had a history of atherosclerotic cardiovascular disease. And it's important because in this particular randomized study, they found that for every 20 milligram reduction in LDL cholesterol, that actually translated to a 25% reduction in the risk of having an ischemic stroke. So a focus on significantly modifying these risk factors is really important. Well, women, as I mentioned, tend to face a higher risk of stroke, especially as we get older. 1 in 5 women will have a stroke. Among women, Black women have the highest prevalence of stroke amongst other race and ethnicities. And there are some unique risk factors in women that are important to note. Pregnancy tends to be a prothrombotic rate where there's an increased risk of developing clotting and that can contribute to a greater risk of stroke in women. Taking birth control pills or hormone replacement therapy also can increase the risk of stroke for those same reasons, but they also can increase the risk of hypertension, which, as we discussed earlier, is a risk factor for stroke. It's important that we're getting the pregnancy history from our women who have had children, because preeclampsia is a risk factor for stroke later on in life. And then we talked about atrial fibrillation as a risk factor as well. I want to talk about two other non-traditional risk factors that are not often spoken of for stroke. And the first one is lipoprotein A. Lipoprotein A is a genetically predetermined type of cholesterol that looks like the LDL particle, but it has an apolipoprotein A attached to the molecule. And it's this apolipoprotein A that confers its pathognomonic properties to lipoprotein A. Because it's genetically inherited, it is important that we are testing patients at least once in their lifetime, and certainly family members of those who have been identified as having elevated lipoprotein A. A normal lipoprotein A is less than 30 milligrams per deciliter, and we define elevated lipoprotein A as levels greater than 50 milligrams per deciliter. If you're looking at particle numbers, is greater than 125 nanomoles per liter. It is not at all uncommon. About 10 to 30% of the population globally, that's 1.4 billion individuals, or 20% of individuals in the United States, has elevated lipoprotein A. So we definitely need to be screening for it more, because we need to identify these individuals who have this risk factor. And we know that it's a risk factor for stroke because lipoprotein A has been shown to be associated with increased risk of coronary artery disease, ischemic strokes, and certain types of valvular heart disease. The image to the right shows you what happens, or the association between lipoprotein A levels and the risk of having some sort of major adverse cardiovascular event. So that's PAD, stroke, or heart attack. And as you can see that as lipoprotein A levels increase, there's actually increasing risk for developing one of these major adverse cardiac events. Familial hypercholesterolemia is another condition that is associated with increased risk for stroke or heart attack. It's the most common form of a monogenic cardiovascular disease. It's inherited in an autosomal dominant pattern, which means that if one of your parents have it, you have a 50% chance of inheriting it as well. It is underdiagnosed and undertreated. 90% of individuals who have familial hypercholesterolemia actually don't even know it. Currently, we estimate that more than 1 million individuals in the United States are undiagnosed. About 1 in 250 individuals has heterozygous FH, and in homozygous FH is a little bit less common. So what are some of the recommendations from the 2026 ACC/AHA dyslipidemia guideline that we can put into practice to prevent secondary stroke events? The first thing is to address clinical inertia. We talked about identifying those risk factors. We know that dyslipidemia is one of those risk factors, but if you don't know what the lipid level is, how can you actually treat to goal? And so the recommendation from the dyslipidemia guidelines is that every individual above the age of 19 should have a standard non-fasting or fasting lipid profile, just to document a baseline to help estimate their ASCVD risk. And even when they've had an ASCVD event, it helps to guide initiation of lipid-lowering therapy, but also the escalation of lipid-lowering therapy. For those who have a family history of dyslipidemia or premature ASCVD, or if they have hypertriglyceridemia, especially if the triglyceride levels are above 400, then a fasting lipid profile is much more recommended than a non-fasting. For lipoprotein A testing, the 2026 cholesterol guidelines recommend that all individuals, all adults, should undergo lipoprotein A testing at least once in their lifetime. Again, because it's 90% genetically determined, you probably don't need to check it more than once, except in certain situations. Here we see that lipoprotein A levels, as I mentioned earlier, confer increasing risk of ASCVD depending on the level. So even a level of 125 nanomoles per liter, there's a 40% greater risk of having an ASCVD event. So I always like to tell my patients all lipoprotein A is not created equally. The higher the level, the more aggressive we need to be about addressing your risk factors. Well, currently we don't have any FDA-approved therapies, pharmacological therapies to address elevated lipoprotein A. And so the recommendation from the guideline is that all individuals who have elevated lipoprotein A should undergo early modification of cardiovascular risk factors to reduce their risk of ASCVD. And those who have had an event, so stroke, PAD, or a heart attack, and they have elevated lipoprotein A, if they haven't achieved their LDL cholesterol and non-HDL cholesterol goal on a maximally tolerated statin, that a PCSK9 inhibitor should be added to reduce their LDL cholesterol further and to reduce their risk of ASCVD. The guideline provides some recommendations on addressing LDL cholesterol levels based on the risk category for an individual. So if you have clinical ASCVD, you are at very high risk if you've had more than 2 major ASCVD events here. So if you had an acute coronary syndrome or heart attack within the past year, or if you've had an MI prior to that, if you've had an ischemic stroke, or if you have symptomatic peripheral arterial disease. If you have 2 or more of those, you are at very high risk. If you had only one of those major ASCVD events and you have 2 high-risk conditions, 2 or more high-risk conditions, then again, you are considered to be at very high risk. So what do we do with this information? The guideline recommends secondary prevention of ASCVD in adults who are at very high risk should consist of adding a high-intensity statin to achieve a 50% reduction in LDL cholesterol and getting to a target LDL less than 55 and a non-HDL less than 85. If you're already on a maximally tolerated statin, the recommendation is to add ezetimibe or a PCSK9 inhibitor to again reach that target LDL less than 55 or non-HDL less than 85. For those who can't tolerate either of these recommendations, of these medications, in addition to a statin, then the recommendation is that you can consider adding bempedoic acid, which is a medication that addresses the production of cholesterol, the synthesis of cholesterol, with or without ezetimibe or a PCSK9 inhibitor to again reach that same target LDL and non-HDL. And for those who are on a maximally tolerated statin, whether or not they're on ezetimibe, but let's say they cannot either afford a PCSK9 inhibitor or they don't want to self-inject PCSK9 inhibitor, you can consider inclisiran to lower the LDL to the targets already mentioned. The only difference is, unlike statin, Zetia, PCSK9 inhibitor, and bempedoic acid, the cardiovascular outcomes trials for inclisiran are still in progress. And so while it will reduce your LDL cholesterol and your non-HDL, we don't have the evidence yet that it prevents secondary or even primary cardiovascular events. And so that's why they got a 2A recommendation. For those who are not at very high risk, again, the first recommendation here is that we should be adding a statin to those individuals who's had a prior event to again achieve an LDL reduction of at least 50%. And now the target LDL is at less than 70 if they're not at very high risk, and a non-HDL less than 100. If they're already on a maximally tolerated statin and they still haven't reached goal LDL or non-HDL, then it's reasonable to add ezetimibe, the PCSK9 inhibitor, or bempedoic acid. And so this is a nice sort of summary of what we need to be doing to reduce the risk of ASCVD. First and foremost, treating earlier. We recommend screening in children who are 2 years old or older. If there's a family history of premature ASCVD, if they have familial hypercholesterolemia or severe hypercholesterolemia. Otherwise, starting at age 9 to 11 to identify familial hypercholesterolemia or other lipid disorders. If those have already been excluded, by the time they reach age 19, then we recommend screening lipids again, and at least every 5 years if their lipid levels are normal, or you can use the Prevent ASCVD to identify their risk to determine if you need to check it more frequently, or initiate therapy. Aim for a lower lower LDL. We know the lower the better, and so less than 55 if they've had clinical ASCVD and are at very high risk, less than 70 if they have diabetes with other risk factors or coronary calcium. And then checking it every 4 to 12 weeks after you've either started the lipid lowering therapy, or if you've adjusted the dose, then you need to check it within 4 to 12 weeks. So again, addressing that clinical inertia where we start therapy and we never do anything with it. So this is Life's Essential 8, which addresses some of the factors that are important in the prevention of stroke. Certainly getting ideal amounts of sleep. We talked about the diet, and Mediterranean diets is most helpful. Focusing on avoiding processed foods, using healthy fats and lowering sodium. Again, remembering that obesity in and of itself is not just a risk factor, but also physical activity is a risk factor. And so encouraging our patients to participate in physical activity, addressing blood sugar, blood cholesterol, and hypertension if those exist. And again, for those of our patients who are smokers, really providing them with the tools to help quit tobacco. So with that, I'll stop and I'll turn it back over to you, Marie.
All right, thank you so much. That was a great presentation, a real tour de force on lipid management. I really, really appreciate it. So we've heard about the importance of cholesterol management for heart and brain health. So now let's talk about what it looks like in real life from different perspectives. I think we'll start off with Dr. Sara Doyle. How does cholesterol affect both stroke risk and long-term brain health?
That's a good question. So we think about stroke, or we think about cholesterol primarily in two settings related to stroke. So either, you've already had a stroke, and what are we doing to reduce your risk of having another stroke? We're starting to think about it as far as primary prevention of stroke, and I'll talk a little bit more about that. And then the third category, again, this is really the emerging one, and we need more. There's a study that may help inform this better, but as far as lowering cholesterol specifically to protect your cognition and your memory, your cognition, your thinking as we get older. So I know we just had a great presentation about, high cholesterol, particularly high LDL, is a risk factor for stroke and can lead to buildup of athero in your arteries, and that by itself can cause a stroke. And so after somebody's had a stroke, especially if that we focus on lowering your cholesterol, there's a little bit of nuance as far as like, why did the stroke happen, of how aggressively we do that. But that is a major part of the care plan after somebody's had a stroke. A lot of people are like, well, I don't want to have a stroke to begin with. And so guidelines just came out. I was part of that committee, which it was a big lift for the primary prevention of strokes, so preventing strokes from ever happening. And unfortunately, there aren't studies, to get nerdy about it, there aren't studies that have stroke as a primary outcome as far as it relates to cholesterol control. And that's honestly a problem for a lot of these risk factors as far as primary prevention. We just don't have those studies that have followed people for long enough and have a big enough sample size to say, okay, if you get your cholesterol below this, we can definitively say that, that is effective for primary prevention of stroke. So we do what we many often do, is we extrapolate from kind of cardiology studies, kind of good clinical medicine of what kind of makes sense, what's reasonable. And I don't think that we brought this up, but I do love that clinical inertia was identified as a problem, right? And we could have a whole webinar about like contributors to that, and our 12-minute appointments and things like that. But so just to touch briefly on the primary prevention of stroke. So we're thinking about, what can we do so that you don't have a stroke ever in your life? Reasonable cholesterol reduction is a part of that. And so when we wrote these guidelines, the updated ones weren't out, so we used the 2019 guidelines. and said if you are somebody who is at higher risk of having atherosclerotic cardiovascular disease, and your cholesterol is above a certain level, we recommend starting a statin or other therapy. There isn't enough evidence. I get a lot of questions about this in clinic. There's, should I also be taking an omega-3? Should I be taking other red rice yeast or other supplements to help lower my cholesterol? And unfortunately, there just aren't enough, there's not studies to say that is helpful or not helpful. We really have the best evidence with statins or with the other cholesterol medicines. So that's about primary prevention of stroke. And I'll just touch briefly about as it relates to cognition overall. So I think about this both in terms of neurodegenerative disease, like Alzheimer's disease, Parkinson's disease, frontotemporal dementia, but then also vascular disease, because stroke or even that slow accumulation of vascular injury can cause to your brain can cause, decline in your cognitive function. There are some studies, and these are all observational studies, that say statins are good for your brain, good for your cognition. There's some studies that have found that they don't really impact it at all. And these are observational trials. These aren't randomized controlled trials. And then there's some, and this is kind of out in the zeitgeist too, that statins are not good for your cognition. They're not good for your brain as you get older. But there's enough observational studies that are going all in different directions. So there's an ongoing trial now that's a national trial called the Preventable trial, and it's an acronym that they've really made work. But it is giving people 75 and older who don't have any cognitive issues statins. I think it's 40 milligrams of atorvastatin. That's one of our high intensity statins, and following their cognition over time, to kind of put this issue to rest, to say, okay, should statins be a part of brain health care as you get older? Because 75, I think probably the reason they chose 75 is that's really where a lot of our risk studies or our understanding of cardiovascular risk kind of starts to diverge a little bit. And so the preliminary results, I think, are due out at the end of this year. So hopefully at some of the conferences in 2027, we'll have better guidance for our neurologists and our geriatricians and our cardiologists for how to approach statin use and lipid management in our older population.
Okay, and now hearing that, Dr. Isiadinso, whenever you have a patient that is coming to you, so what patient should know before starting cholesterol lowering medication?
What should the patient know, you said?
Yes.
Yeah, well, certainly the first thing we need to do is assess their cardiovascular risk. So if they've never had some sort of cardiovascular event, but if they have risk factors, or if they have a family history, it's important to take that all into account. For those who have never had a primary event, it's helpful to use the Prevent ASTBD risk calculator, which was also published in our 2026 dyslipidemia guidelines. That can provide some guidance about whether or not they should be on any therapy. If they've had an event already, they've had a heart attack, they have PAD, or they've had a stroke, then we know they need to be on lipid-lowering therapy, because there's several studies that have shown proven benefits that if you lower the LDL, and certainly even if their LDL is normal, that putting them on a statin prevents cardiovascular events. I also like to ask patients if they're having any symptoms. I think, as you heard already, there are some studies ongoing to see if cognitive decline is an issue with statin therapies. I had 3 patients already bring that up today who need to be on lipid-lowering therapy. And so I like to at least sort of dispel some of the myths, because if you don't address those up front, the patient's going to take your prescription. They're either never going to fill it, or they'll fill it and they won't take it. So I think certainly at baseline, understanding if they have any concerns, if they have any financial burden that will prevent them from taking the medication, and primarily if they have any questions about the efficacy of the medication. I think addressing those upfront and knowing their risk is most helpful at that first visit when you're talking about starting lipid-lowering therapy.
Thanks so much. Then we'll turn to you, Brooklyn. What are the most common side effects patients report with cholesterol-lowering medications, and how do you help them sort of manage these side effects?
Yeah, so, when we think about cholesterol lowering medications, there's so many different groups, and really focusing on some of the more common ones, the ones that we've previously discussed in the earlier presentation. With statins, the most common patient reported issue is going to be the muscle symptoms. We know the myalgias, the cramping, the weakness. We do know that true severe muscle injury is pretty rare, but I do recognize that if patients experience even just that slight myalgia, that's very real to the patient, and we know it to be a big driver of medication non-adherence. With statins, I also counsel about the mild liver enzyme elevations, though usually that's pretty asymptomatic, and the small increase in glucose or diabetes that can occur in certain patients. For ezetimibe, generally very well tolerated. Some patients might experience a little GI upset or a little bit of muscle symptoms, but it's usually a lot easier to tolerate than a lot of people expect. Our PCSK9 inhibitors, the main things we'll hear are the injection site reactions. Some patients might experience flu-like symptoms, but the biggest thing with these medications, maybe not necessarily a side effect, but it is the access issue, making sure that patients can afford and get that medication. And then lastly, I know we mentioned bempedoic acid earlier. Typically, if that's prescribed, we need to be thinking about uric acid elevation, gout, tendon symptoms that can occur, and then also drug interactions can be a big deal with that medication group. I think the biggest thing, though, when we're talking to patients about side effects, is the importance of validating those side effects in patients if they do experience them, but making sure that we're emphasizing that stopping these therapies, especially after an ischemic stroke, can carry major long-term risk and complications. So making sure that they're educated, and letting them know that there's always other options that we can do. If it is trying a lower dose of a medication, switching it, holding it for a break, re-challenging it. I think all of these things are really important when we're talking to the patient from a side effects standpoint.
Okay.
Thank you so
Yes. Thank you so much. And then actually, this question goes like handy with with Maria Jamilla Lacap. It's what system levels keep patients from reaching their LDL levels, even when the effective treatment exists?
I think one of the biggest challenges is implementing evidence-based care consistently across the healthcare systems. Patients usually transition from the hospital, the specialists, primary care providers, and they just kind of get lost with their follow-ups, their lipid monitoring and treatment reassessment, and then also keeping up with the guidelines. We just had a recently change in those guidelines. And so just a lot of, opportunities there that we can optimize. I mean, the treatment is available, but just trying to keep up with everything that's going on. And then, Dr. Doyle, you had mentioned about patients having limited time, with the providers and providing all these education and answering all those questions. So a lot of opportunities there.
Thank you, Maria. And now we'll turn to Cheryl. Did you know that you had high cholesterol before you had a stroke?
Thank you, Dr. Denny. I did not. I had no clue. Probably should have known, because apparently after I dug into my family history a bit, found out that both of my parents had high cholesterol and had been on a statin. And talking to my older brother, he revealed to me that he also had high cholesterol and had been on a statin for a number of years until he got it under control. My reaction to statins, rather, because we tried several different ones. We tried different dosages. And am I okay now on camera?
Yes.
Yeah,
Okay,
we can
thank
see you
you.
now.
Okay, thank you. I had no idea about high cholesterol, that I had it. But after digging into my family history, talking to my brother, both my parents had high cholesterol. He had high cholesterol and managed it with a statin. Unfortunately, my experience with a statin was very, very negative. I had debilitating aches and pains, migraines, and I was unable to sleep. And through advocacy with my neurologist and my primary care physician, landed on Repatha. And it really did the trick. it lowered my statin to a point where it's no longer a concern for me or my medical team or my family. And that's another thing that I can share, is that my family has been so supportive. And I call them my medical team.
Thank you so much. Really appreciate your insights on that. Yeah, maybe we'll head back then, I think, to the maybe Dr. Doyle again. Marielle, did you want to pose the next question?
Yes. So now that we heard like an experience from a patient, so and what can you tell us from other patients that are the most common misconceptions have about cholesterol and statins?
So I think I'll just share anecdotally, like the things that I've heard in the clinic. Muscle aches and pains are certainly the biggest one. And, we work with patients to reduce the dose or to try a different one and see if they can tolerate that better. Engage with our pharmacy colleagues a lot about other options that they may be eligible. Repatha being a favorite as well for the people who really can't tolerate them at all. Those are probably the biggest, or what comes up clinically the most. I get questions from residents about, well, how high is too high? When should I be checking a CK? And there can be a specific type of myositis that's rare, but it can cause pretty significant muscle injury. Those are usually the patients we're seeing, we see them in the hospital because they're pretty debilitated by the pain. And so we test for that and certainly stop. It can take a little while for that to come back. So we usually just stop it preemptively and wait for that to come back, because even if it's not that kind of unique muscle injury pattern, if the pain is so bad, we're going to be thinking about other ones. I haven't gotten quite as many, I think, as there has been a shifting, social media presence about lipid testing, advanced lipid testing, and dietary patterns. I've gotten some questions about, well, isn't there some fats and cholesterol that are good for the brain, or what does it mean that my Lp(a) is elevated when we're thinking about dementia or stroke? And unfortunately, we just don't have good longitudinal studies on there. So we have to focus on bringing it back to, okay, here is what we have randomized control evidence for. So I think that's the flavor of what comes up in my clinical practice of the muscle aches and pains. With residents, it's talking about the myositis risk, and then some of these more advanced testing, or do I really need this? Isn't there some amount of fats that are good for me? That we're having those clinical discussions too.
Great. Thank you so much. And then for Dr. Isiadinso, what other non-traditional risk factors should be considered in a person who has a stroke? Maybe thinking sort of particularly about our previous discussion on lipoprotein A and familial hyperlipidemia.
Yeah, thanks for that question, Dr. Denny. So I highlighted those in a talk because we don't really cover those often. And I think certainly before I became familiar with those risk factors, I've been in the field now at least 16 years, that I didn't talk about. And I probably didn't know about it when I was training about FH or elevated lipoprotein A. Thankfully, elevated lipoprotein A is getting increasing recognition, and we included it as part of our guideline. I happen to be part of that writing committee for the 2026 dyslipidemia guideline. And we felt it was really important to make that recommendation, that everyone get a lipoprotein A checked at least once in their lifetime. And so that conversation can happen. Pregnancy history, as I mentioned, is another one. We need to definitely be talking to our patients who've had children about their pregnancy history, because we know that hypertension, disorders of pregnancy, whether eclampsia, preeclampsia, gestational diabetes, those all increase risk of cardiovascular disease as well later on in life. And then I just want to address what somebody has asked here in the chat, because it does pertain to lipoprotein A, is that right now there are no FDA approved therapies. And so the focus is on addressing those risk factors. And then more importantly, the other benefit in identifying those who may have elevated lipoprotein A, because we should have some results of these cardiovascular outcome trials later on this year. And so knowing who has elevated lipoprotein A, if they've had a stroke event, then these may be individuals who will benefit from those therapies if those trials end up being positive. Currently, right now, the only other option for those who have elevated lipoprotein A, specifically to lower their levels, is lipoprotein apheresis. And it's like a dialysis type of procedure where you remove the lipoprotein A from the bloodstream. But because we make it, it comes back in several weeks. And so you've got to do that treatment every 2 weeks or so. And it lowers lipoprotein A by about 40% on average per session. And it's shown to also reduce cardiovascular events. So that's all that we have right now. But we definitely need to be focusing on all the other risk factors, including aggressive modification of LDL cholesterol, not just with statins, but the PCSK9 inhibitors. And the reason I really mention that one is because that has been shown in some groups of individual subpopulations for both the FOURIER and Odyssey outcomes trial, that those individuals who had high lipoprotein A, that the PCSK9 inhibitors actually lowered lipoprotein A by 20 to 25%. So if I have somebody on a maximal dose of statin that they can tolerate, if their LDL is high and they happen to also have high lipoprotein A, instead of reaching for the Zetia or the bempedoic acid, I'll just actually reach for that PCSK9 inhibitor, because I know it's going to reduce the LDL by 50% and it'll reduce the lipoprotein A by 20 to 25% as well.
Great, thank you so much. That was a really helpful and comprehensive answer.
Sorry, let me see. We have next Brooklyn. So how can pharmacists help patients balance concerns about medication side effects with the long-term benefits of stroke prevention?
Yeah, I think, education, of course, it always comes back to education. One of the biggest things I try to remind patients, especially after a stroke, is that every medication really has a purpose in reducing that risk of another stroke. Whether we're controlling your blood pressure, managing your diabetes, preventing blood clots, like all of these medications work hand in hand to help prevent another event. Unfortunately, I think a lot of patients might experience a side effect or read something online or hear a story from a friend or family member, and then that might ultimately result in them stopping the medication before sometimes they even talk to the healthcare providers first about it. So when patients are really worried about the side effects, I try to make sure that I'm acknowledging it and letting them know we have options. For example, Cheryl was sharing that a statin didn't work for her, and so they were able to get her on a therapy that did work to have her LDL significantly lowered. We've got other medications. We can adjust the dose, change the statin, all these things that we've mentioned before. I think the most important thing when we're talking to patients about side effects and how we can balance that with the benefit of these cholesterol lowering medications is translating that risk into something that matters to the patient. And that's with every disease state, we should be doing that. So patients maybe, they might, for example, they feel the muscle pain on the day-to-day, but they don't necessarily feel their LDL. They don't feel plaque progression. So when we're talking to them, numbers don't always mean as much to patients. What they care about is, are these medications going to preserve my independence? Is it going to help keep me out of the hospital? Is it going to help me to not be disabled later on in life? Is it going to help me with my quality of life? So translating, the role of these medications into the practical things that patients care about, I think is a really great way to kind of help balance the side effects of treatment, educating them on that component, but also making sure that they feel confident and comfortable and want to stay on these therapies for that long-term stroke prevention benefit.
Thank you so much. And then we'll turn again to Maria. Can you explain the best practice alert, abbreviated BPA, that was developed by Ken Chan as part of EPIC, the medical record? and how tools like that may improve care delivery.
Yes, so the BPA was developed to help identify patients who may benefit from additional lipid evaluation or guideline-directed therapy. So it's going to provide, to the provider a workflow and helping to reduce those missed opportunities to help ensure patients are on the right target goal for their LDL, and just to share across the different care across the different specialties. And so it's just basically just additional tool to make sure patients are on the right treatments.
Is it like a pop-up in the medical record?
It is. And so when you have a certain diagnosis, say for instance, hyperlipidemia, then an alert will come up and say, hey, this patient has this diagnosis. Should you make adjustments to their statin therapy based on this? Is there an LDL that, or, recent lipid profile, or do you need to order one? So it's just an alarm that triggers up, when you're in the patient's chart.
Thank you.
That sounds great, actually. And it should be helpful for the clinicians in the future just to keep an eye on their patients, especially having them under control and keeping them in the radar.
Correct. Yeah.
Yeah. So I want to ask Cheryl, what advice would you give others trying to manage your cholesterol or reduce their stroke risk?
Thank you for that question, Marielle. I would say be your own best advocate. Do what you can do. And I was raised with the adage that said, a squeaky wheel gets the grease. Don't back down from advocating for yourself. And I've been very fortunate to have very good medical care throughout the years. So I've always been involved in my medical care. And one thing I knew for sure after my stroke, I wanted to be here to be a part of my grandchildren's lives, to watch them flourish and to watch them grow. And I've also know that many people cannot be an advocate for themselves, or they don't have advocacy in them or ability to have anyone advocate for them. And I wanted to speak up for my community. And I mean the community of survivors. I mean the African American community. I mean women. I mean all of those things. I wanted to be a person who could stand up and speak out and maybe help someone else. And I've been given many opportunities to do that, thanks to the great care and the support I've gotten from my family and my circle of influence. So thank you.
Thank you so much. And actually, we have some minutes, and if you still want to do like the Q&A session, we have some questions prepared for you. So let's go back with Dr. Doyle. So whenever we have someone that might be asking, how early should people begin thinking about prevention? What would you say?
I would say it's never too early, and to also balance that against like reasonableness, right? To not be optimization at all costs comes with a cost, right? And so a lot of when I'm thinking about dementia or thinking about stroke, a lot of studies point to kind of early and middle adulthood as when, a lot of it starts to make a difference. Having good blood pressure control or, maintaining good blood pressure control throughout your adulthood makes a difference. Having good cholesterol control, being aware of knowing what your numbers are. I don't know if that's still a campaign that the NIH is doing, but they had it a few years ago of just knowing what your numbers are, knowing what is my blood pressure at, what's my blood sugar at, what is my cholesterol, and, coupling that with, working with your clinician and maybe moving their, kind of combating some of their inertia possibly. But, early and middle adulthood, your health status then matters for your health status in late life and maintaining your independence for as long as possible. Of course, if you're going to spin out about exactly what you should be eating, maybe that's a time to look at some of the anxiety that can come when we start to talk about these things. But I think, You know, a lot of these risk factors we've been talking about, they have a cumulative effect. And so if you know, when the guidelines are saying we should know as young as 19, we should be screening for testing what your lipid panel is. And I think that just points to, you know, how your health in early and middle adulthood has a big impact in on your health in late adulthood. And so I don't think there's ever too early of a time to be thinking about prevention, and balancing that against, good reasonableness and not letting anxiety take over.
Thank you. So we have a couple of questions on the Q&A. Whoever wants to respond, it's welcome to do it. So the first one, Dr. Isiadinso, I see that it's answering. I'm going to go with the second one, and that's something that we might need to talk about. And it's regarding diet and the importance of combining medication and diet to do changes on their cholesterol. So many of our patients feel that they can rely on diet alone, but we know that the best approach is addressing all the factors with lifestyle and medication. So what's the biggest recommendation on that?
Sorry, I think what we're trying to ask is, how would you counsel your patients regarding the best choice of diet in terms of, cholesterol lowering? I think that's what the question is getting at.
I'm happy to take a stab at that and have others chime in. So, as part of our dyslipidemia guideline, what we recommended was incorporation or adoption of a diet that is low in saturated in trans fats, that is high in fiber, avoiding simple sugars, a diet that's also high in legumes, protein, things like that, because those have been shown to lower not just LDL cholesterol, but also risk of ASCVD. And I think somebody asked a question there about the portfolio diet. And there was a clinical trial that looked at the portfolio diet, and it was found to lower LDL cholesterol by 25 points, if I have the number correctly. And the diet was high in nuts, fiber, and it also contained plant sterols, which is a natural component of certain foods that actually lowers LDL cholesterols. And so that is primarily what we recommend. And there's a great opportunity to modify diet to achieve that goal.
Mario, can I just drop in here? Something that I would advocate would be an exercise program, even if it's just walking, even if it's with a buddy that you can find, maybe in your neighborhood, a walk group. Or if there's a way you can get into a gym, that if you can afford one or if you can be accommodated. I started an exercise program for seniors, and I've stuck to it for 7 or 8 years. And I think that has helped along with my diet and changing my lifestyle.
Thank you, Cheryl. You're the best. And maybe another question from the audience. There was a question about, are there scenarios when providers can reduce the dose of statins, or do high intensity statins need to be continued lifelong? And I think this will maybe be our last question, or maybe second to last.
Go ahead.
Okay. I was going to say, I have de-escalated doses, but it's not the norm. I think, as you heard from Dr. Doyle, one of the challenges patients express is whether or not they're having side effects and symptoms, whether they're real or not. If a patient expresses it and they're going to not adhere to the therapy, then you need to figure out what to do, right? Because what you're really trying to do is prevent that first or second event. And so there are some patients that prefer not to take a daily medication. And so if they have had an event and they are on, let's say, a statin and they're reporting side effects, or they just don't feel like taking it consistently, I will reduce the dose if they're complaining about the myalgias, but I will then add a PCSK9 inhibitor or add something else that they are willing to take, again, just so we can remain at target LDL level. So the goal is to work with the patients to get them on therapy to prevent an event. That's the end game there.
Thank you all so much. We're at the hour. Really, really appreciate this panel. You're all getting shout outs in the chat, especially Cheryl Benton, our most wonderful stroke survivor and advocate. So really thank this panel and Dr. Isiadinso for her wonderful talk. Hopefully you'll be able to join us for future webinars. Keep an eye on the Connect website, which is www.connectstroke.org. You can sign up for our emails and you will know about future webinars on stroke-related topics. Thank you again, everybody. Really appreciate your time and have a great rest of your day.
Thank you, everybody.
Thanks, everyone.